Welcome, welcome in. Welcome, welcome in. We'll give folks a few moments to arrive. We're so glad that you're here and joining us this afternoon. Thank you, Sharon. Teamwork, collaboration. Thank you, Cassandra, for playing the music. It's good to see faces here, people here, known and unknown. I can't see your faces, but I can feel your presence, and we're all glad that you're here. And we'll start in just a few minutes. So gather in, settle in, get comfortable. If you'd like, you can join me in just a few calming breaths, breathing, feeling your back, feeling your feet. Noticing the expansion of your ribs as you inhale. And noticing a contraction and release as you exhale. Welcome to Health Equity Action Time Heat, Session 1, Critical Reflections and a Shared Path Forward. And in the service of time, we're going to begin. We want to start by acknowledging that UCSF sits on unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. We further acknowledge, given that our UCSF system is large and vast, that the Greater Bay Area is the ancestral territory of the Miwok, Yokuts, and Patwin, as well as other Ohlone peoples. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all the people who reside in their traditional territory. As guests, we recognize that we benefit from living and working and loving on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, the elders, and the relatives, all the relatives of the Ramaytush community, and by affirming their sovereign rights as First People. We offer our respect, our partnership, and our gratitude. We want to invite you into the spirit of health equity and Sankofa. Our colleague Cynthia Dillard shares that we believe one cannot simply forget about a deeply inflicted wound by ignoring it long enough. Indeed, from some cultural stances, the circularity of time and its relationship with spirit means that past, present, and future are intertwined, which is why it's important to remember what we have learned to forget. So as we begin again this journey of health equity, we invite you into the spirit of Sankofa. And Sankofa, for those who are learning about it today, is a word from the Twi language from Ghana, which means to retrieve, to go back and get, to bring back from the past what is good, what is wise, as we move into the future. So this image, as you see, is an image of a bird with its feet planted firmly in the ground, and it's looking back as it prepares its flight forward. So health equity is ensuring that everyone has fair and just opportunities to be as healthy as possible. And together we can dismantle the barriers to health equity by remembering those who came before, by inspiring one another, by holding each other accountable. So let's take a moment together to remember and acknowledge the shoulders upon who we stand. And we are all part of this long arc towards providing access to health equity. We want to go back and remember those who've guided us to this moment. So I invite each of us, each of you, to take this moment to bring to your mind and to your heart someone whose shoulder upon who you stand, whose actions that you stand upon today in our shared movement towards health equity. It may be an ancestor or a colleague, it may be a guide or a mentor, or perhaps a patient or a client or a young person who inspires you in your work. If you'd like, you can put their name in the chat, or you can just bring them fully to your mind and to your heart right now. We take this moment to remember because this work takes sustained energy and action, right? Sustained energy and action. We are in year 2, right? After a pandemic, right? We are here today to generate hope, to bring forward action and things that we can keep moving on. And in order to do that, we need to lend it to Sankofa, gathering the wisdom of the past as we move into the future. So for me, it's Dr. Sue Park, who is a Korean immigrant and founder of our school-based behavioral health programs, and Dr. Barbara Saggers, a Black woman, adolescent specialist. She not only started our school-based health centers, but also pioneered adolescent medicine at Children's Hospital, Oakland. So they both guide me and many others through their actions and through their fierce commitment rooted in love. They showed me how to forge a path forward towards health equity with persistence and always keeping our relationships with the communities that we serve at the center. It will take our individual and collective actions and sustained efforts to uproot institutional and historical racism that lives in our medical and behavioral health systems. As Marian Kaba, who's a Black abolitionist, says, hope is a discipline that we have to cultivate every day. And so this seminar, this gathering, is an act of hope that together we can eliminate health disparities and ensure health equity for all children. In fact, it's absolutely necessary, right, for our collective survival and liberation. The purpose of this series is to increase health equity in child and adolescent behavioral health throughout our system. And we can't talk about equity without talking about social justice. In fact, sometimes I wonder if equity is kind of a watered down version of the word justice, right? So when we talk about social justice, we must center race and acknowledge the part that racism, institutional, historical racism, and white supremacy play as a foundational organizing principle in the development of our country and in our healthcare system. So structural oppression, including racism and colonization, is the root cause of health disparities, not race. Right? And if you're just kind of, I know we've had this conversation as a community, if you're just jumping onto this conversation, you know, I invite you to look at Dr. Joy DeGrew's research and many others. Our healthcare system here at UCSF can be, and sometimes is, a healing system. But in order for our healthcare system and behavioral health systems to be truly healing, we must both recognize and go beyond recognizing systemic and structural racism by investing in structural change in which children and families are nurtured, supported, valued, and consistently giving the messages that their lives matter. As our sister, Adrienne Marie Brown says, I think it's healing behavior to look at something so broken and see the possibilities and wholeness in it. So what does health equity and behavioral health look and feel like? Right, again, what does health equity and behavioral health look and feel like? This past year, I had 2 family members with potentially terminal illnesses. So one was diagnosed with acute myeloid leukemia and the other was struggling with depression and mental health. So guess which one it was easier to access healthcare for, right? The medical condition, the leukemia, much easier to access healthcare than it was for mental health. If today a child or adolescent walked into our school-based health clinic, it would be much easier for them to get a medical appointment within 3 days, and they might be on a wait list to get an appointment for behavioral health. So in this age of these conditions of pandemic, of climate crisis, and reckoning with our collective trauma history and prevailing inequities, what does behavioral health equity look and feel like? We need to have a vision. We need all of us to really vision and put that vision into action. Because we're seeing and hearing and feeling, right, that our children are in a mental health crisis. In our healthcare facilities, in our families, in our communities, we see a significant increase of suicidal behaviors for Black and Indigenous children, right? Children and adolescents who have traveled from their home countries in Central America, impacted by violence, arrive with profound experiences of trauma, often arriving to their new homes with bare bones support. Lesbian, gay, bisexual, and transsexual and queer communities continue to have high rates of suicide and suicidal behaviors. And that's just one measure of the state of mental health. So inside of this, we're called to create a vision together where we have a world and a healthcare system where adolescents, children, and their families are thriving. A world where they and their caregivers and communities are connected to their innate ability to heal. So this includes on-demand and barrier-free, culturally accountable and evidence-based behavioral health care, where children are in school, in their communities, in their homes, in the playground, in their places of worship, in our clinics, and in our hospital. Health equity and health justice draws also from community members' traditions, from those cultures, those practices, those values, and the programs that we have across our system that integrate cultural-based and evidence-based practices will be the ones that are most effective for the populations who have been exposed to the trauma of oppression. As Dr. Melanie Trevelyan and Jan Murray Garcia, rooted right here in the 90s, right, in our children's hospital system, they showed us that health equity demands a stance of cultural humility, that we need to prioritize partnering with community members and institutional accountability, and a lifelong commitment of self-evaluation and self-critique. So that's what we're calling upon us to do together today. Again, healing behavior is looking at something so broken and seeing the possibility and wholeness in it. Dialectical behavioral therapy, DBT, invites us to hold the dialectics and search for synergy. So a few dialectics that we can hold together is that we're part of a healthcare system that has institutionalized racist, white supremacist, patriarchal practices and policies right now today that show up in our healthcare system. And we're also in an institution and community that's committed to anti-racist, transformative, and liberatory practices, policies, and values that show up right now today in our healthcare system. Let's acknowledge that there is harm and healing happening. Let's acknowledge the presence of both hopelessness and hope. Let's be both gentle and fierce with one another in our commitments. Again, Miriam Kava, hope is a discipline. Hope is a discipline that we need to practice and cultivate every single day. So as we enter into the seminar today, let's be in authentic conversations with ourselves and with each other to center health equity, to center health justice, and continue to water these seeds of hope and healing. Let us remember the spirit of Sankofa. Let's reach back and gather the wisdom of the past as we fly together into this future that we are dreaming of for ourselves, for our children, and for our organization and communities. I'm going to pass it to my colleagues. I'm so grateful to be part of the team together and that we're all here in community. And I'll pass it to Anda.
Hi, I'm so sorry. Hopefully you can all hear me. There goes my video. There we go. Thank you so much, Saun-Toy. That was beautiful. And thank you for grounding us in what's important today. Really appreciate everyone taking time out of their incredibly busy days to be with us here today to discuss this important topic. And you know, if this was an easy task to do, we wouldn't be here today. So we want to make sure that we ground ourselves in a few community ground rules. Sorry, I'm having trouble with my Zoom for 1 second. Okay. And we know that so many of our colleagues and partners have been working incredibly hard to provide care and improve care for children and adolescents with mental health needs. And it's not enough. It's just the need is so tremendous and we want to and can do better. So to engage in a fruitful way on this journey over this 3-part series, we propose some community rules to guide us. So 1, honor multiple perspectives. We respect that other people's experiences might be different from our own, and we seek to engage with difference from a place of curiosity. 2, create brave spaces. We pay attention to and are responsive to each other's needs, and we each create conditions for safety so others can be brave. And we own the intention and impact of our words and actions. 3, hold patience and urgency. And I want to highlight this because we've set a table, but it's really all of you and the expertise and perspectives you bring that will carry this work forward. And we want to strike a balance between actively rejecting what is not working in the status quo while accepting that we can't solve everything today. So we seek progress over perfection. Take the lessons forward, leave the stories behind. We accept that we are all individual owners of our own narratives, and we respect our peers' confidentiality and commit to taking learnings forward into our professional and personal lives. Finally, commit to collaboration and learning. That's why we're here today. We believe in working together to achieve more than what we can do individually, and we're open to learning, sharing, and exchanging. You can go to the next slide, Cassandra. So just a quick, we have a jam-packed agenda. I'm going to move us along just so we stay on time. We have a 10-minute break coming up at 2:45, and we are going to hear from some incredible voices and expertise throughout today. And again, so grateful that you're each here. So I can't tell you how thrilled we are to have arrived to this day and launch this series. It's been quite a long planning process with many of you involved. I'm so grateful. After today, on May 24th, we're going to continue our conversation examining the unprecedented reform landscape in California and what that means for Bay Area children and families, bringing in deep expertise from Dr. Tom Insel, Mark Galley, Melanie Moore, Brian King, Lisa Fortuna, as well as Alex Briscoe and Ann Coons, among others. And most importantly, our final session on June 28th will take what we have shared and learned in the first 2 sessions to develop a roadmap forward with many of our system leaders from the Department of Pediatrics, Benioff Children's Hospitals, County Mental Health, and other partners. Many of you are here today again. And we just want to provide some context for this HEAT series, as improving the mental health and well-being of children and young adults is a multifaceted and multi-sector endeavor with numerous perspectives and contributing factors. So an important frame of reference is that the impetus for this series came from non-mental health child and adolescent providers that were sharing about the challenges and the opportunities of supporting patients with mental health needs in our various clinical settings through a collaborative cross-site, cross-disciplinary, cross-service task force that was meeting during the pandemic to discuss and share and collaborate around the evolving needs we were seeing in our clinical spaces during the pandemic. And in that context, I just want to have a shout out to that collaborative space. That was our social needs task force that continues to meet monthly, the fourth Thursday of each month. Please join us if you're interested. We meet from 9:10 to 10. And also to our incredible HEAT Planning Committee team members who've been meeting twice a month for the past 6 months or so, and have been dedicating a lot of time and experience to the series. And in particular, I want to thank Cassandra Vega, our Center for Child and Community Health project manager, who's done an amazing job pulling the series together. And on behalf of our center, we share deep gratitude to our co-sponsors of the series, the School of Medicine under the guidance of Kirsten Bivens-Domingo and Kelly Mead and the Department of Pediatrics. And finally, really thank you to the fantastic group of presenters today who are leaders on the forefront in various clinical settings and sites and have taken time to share their expertise with us. Many of you know that the CDC recently released data from the Adolescent Behaviors and Experiences Survey. It's a 110-question online survey completed by U.S. high school students from January to June in 2021, including a lot of questions that came from the 2021 Youth Risk Behavior Surveillance Survey that's normally distributed. There are 128 schools that were private and public schools, and the vast majority were completed in English, even though there was a Spanish survey option. And I show some data here. In addition to the highly concerning data that you see here, with 44% of youth experience significant and disruptive symptoms of hopelessness and sadness, and 1 out of 5 youth seriously considering suicide in the prior year. More than half reported they experienced emotional abuse by a parent or other adults in the home, including swearing, insulting, or putting down the student. And 11% experienced physical abuse by a parent or other adult in the home. More than a quarter reported a parent or other adult in their home had lost their job. And disproportionately, these areas were impacting certain groups, youth identifying as LGBTQ, female, and BIPOC. And then one last important data point, compared to 2019, the proportion of mental health related emergency department visits in 2020 increased approximately 31% among youth aged 12 to 17. And I know we all felt that. Lastly, I just wanted to highlight mental health needs were rising, as many of you know, prior to the pandemic. It's not like a crisis just erupted. It's been just like percolating and percolating. We're just overflowing. This is local data from kidsdata.org, and it shows that from grades 7, 9, and 11, from 2011 to 13 in our 2 counties, and to 2017 and 19, the increase in depression-related feelings. And I just want to highlight that depression-related feelings sounds, not that severe, but the question actually is, in the previous year, felt so sad or hopeless almost every day for 2 weeks or more that they stopped doing some usual activities. And I just think about all the patients that I've seen, and I know many of you have seen, that it's been incredibly challenging. And many of people that we spoke with, providers doing our landscape mapping, spoke about their own, not only in the professional front, but in the personal front, managing the rising needs of their own loved ones and youth in their lives. So while quantitative and population data are powerful, there's nothing more powerful than hearing the perspectives of our youth and their experiences walking through our systems of care. And it's imperative, as we imagine our systems of care, that we ground ourselves in lived experience and expertise. And so it's with great honor and gratitude that we welcome Malia Knapps and Tony Coulter. Malia Knapps is an undergraduate student at the University of California, Berkeley, majoring in social welfare and minoring in education. She's an experienced Berkeley transfer coordinator and research student with the Ronald E. McNair Social Scholar Program, conducting research on weight stigma through anti-Blackness and the mammy stereotype. She'll be followed by Tony Coulter. Tony is a Castlemont High School sophomore and Castlemont Youth Wellness Advisory Board member. Thank you so much for sharing your experience and expertise with us today. There you are, Malia.
Yes, hi. Hi everyone. It's really great to be with you all today. So I really wanted to share my experience with seeking out mental health services and the type of support that I received. So around 14, I was experiencing a lot of symptoms. And at the time, I didn't know what they were, but I knew that they didn't feel great. And my family is African American, multi-generational, and they don't talk about mental health at all. And it's very clear that we do have a problem within the family with mental health. And I've seen a lot of the adults around me unable to speak on it, get services, or recognize therapy and mental health services as a safe space. But I knew that what was going on with me was serious. And so I decided to become my own advocate. And I convinced my mom at the age of 14 to let me seek out mental health services. And for me, it was really life-changing. And I think it allowed me as well to really work through knowing that mental health care can be a safe space, and it can be something to be talked about and discussed. And it was through my work with Saun-Toy that I really grew a lot, and I was able to find community. I was able to talk about my experiences with mental health a lot more. And I also felt safe as well to be a lot more honest about what was going on in my home environment and at school as well, and what kind of led me to seek out mental health services. And so with the help of Saun-Toy, we worked through treatment plans, and I believe that I was able to find one that worked for me, and it was super supportive and really allowed me to be more comfortable going to therapy. And during that time as well, I experienced a lot of food insecurity, housing insecurity, and also a great need for transportation. And so with that, Saun-Toy as well was more than willing to meet me halfway to make sure that I was able to get my therapy services and get the resources I need as well. And so that also helped me greatly improve some of my circumstances, and also making sure that I was able to go to my mental health services and just all of that. And so I think that my favorite thing was my walk and talk sessions with Saun-Toy. I thought that it was really great because I felt like therapy was something that didn't accommodate you and your needs, and that there was no one that was going to be willing to meet you halfway. But Saun-Toy did that, and it made it a lot easier for me to really make my sessions and really just be a lot more comfortable as well, because there were a lot of times where I wasn't able to be present, and it made it really hard for me because therapy is something that I love, and I loved back then as well. So with that, I felt as if Saun-Toy was someone who was really inspirational. And at that age, with the amount of support that I was getting, I decided that I would take my own route and also become a therapist as well, who would provide those same services. And I feel like through seeking those services, especially working with Saun-Toy, that I've had a big turnaround, and I'm really able to recognize my mental health, what it means to seek treatment, what it means to be comfortable what it means to be safe as well in the environment without being punished. And now as an adult, I am pursuing social welfare in hopes of becoming a clinical social worker and pursuing my education minor as well to really get an understanding of what children need as well, because I was in their shoes at one point and I often felt as if I wasn't given the resources to thrive. And I often feel as if, and I still feel this way, if we don't have our basic needs resources, if we don't have housing, food, job security, transportation, we can't focus on our mental health. And so now at UC Berkeley, I am making it my mission to understand as well from children's perspectives and what they need. And I've also observed that children do have a great need for mental health services, and it's really important that we provide that for them. Thank you.
Thank you so much, Malia. Tony, are you available? Thank you. And I may ask both of you if there is like a particular barrier you encountered and facilitate, like something that helped you and something that was hard in our system to navigate. That would be really great for us to spotlight for us. Thank you so much for sharing.
Can you guys hear me? Okay.
Yeah.
Okay. Well, for me, I'm trying not to get emotional, y'all. With me, I've always struggled with like my mental health and depression. But at the time, I did not know I had depression, but I did show some symptoms of it. I first got my therapist in elementary school, and I had her up till, I think, fifth grade, because that's when I was moving to Oakland. So I didn't necessarily have a lot of resources with my mental health. I was battling with it a lot. I mean, I still am, but you know, I'm learning how to cope with it in a healthier way. With my family, they don't believe in like mental health or like depression. They don't believe in that, which was like really hard because like when I would deal with it, I would want to tell my parents, but like I couldn't. I currently want a therapist because like I do need someone to talk to other than my friends. But with my school, we don't have that type of resources. We do not have enough therapists. There's only like 2, I believe, and they have a lot of kids, and I'm still on a waiting list. Yeah, you pause. Okay, I'm gonna cry. I have to pause for a sec. Yeah.
Tony, we
take
so
all the
appreciate
time.
you. Yeah, take the time that you need. And Sky, I know you're there with Tony. And so we really appreciate you sharing and being vulnerable and honest with us. And I agree, you're getting so much positive affirmation that you're so brave, and thank you for sharing. I'm just gonna pause and give space for a minute. And we're also happy to circle back with you at any point.
And one thing, and we don't want to be, it's so resilient and brave, and appreciate Tony and Malia and for sharing. And our goal is to really learn from you, and even without sharing the details of your experience, if there are areas in the system that seem like it helped you in particular, or might have been a particular barrier, we would love any information around that as well. But totally, understand how challenging this is. Many of us, again, have our patients and our own family members that have been navigating this challenging system, which is why we're here today.
So
Malia, if you're available, oh, sorry, Dan, I was just going to see if Malia is available to come back for just a bit.
I am.
Yeah, it sounds like, I mean, it's beautiful, the connection you had with Saun-Toy. And I don't remember if you specified, like, what was the connecting point? Was it the school that connected you with the services? Because it happened to be school-based?
Yes, it was my doctor at the time, Dr. Jave Ross. And at the time, I did not attend that school, but Dr. Ross was really confident that I could utilize those services. And I had spoken to other therapists and other services based at my school at the time, but they weren't sufficient enough. So I felt really comfortable going to seek out services with Saun-Toy and my other therapist at the time, because the environment was so different, and they were really more committed to offering me those services as well. And also, if there are any questions in the chat, I would be free to answer those as well.
I did have one last question, and then we'll move on. And again, thank you both for the courage and just inspiring us and being our future generations. Just so important to us, and we want to support the well-being of all the young adults who are going to be leading us. So was often, I've experienced in my own clinic, the challenge of transitioning from, like, once you turn 18, suddenly the support systems change in the system, and it may not be apparent or not. I didn't know if the transition when you left high school to college was smooth or not for you.
I think, well, my mom decided that I could make my own decisions around my mental health, which was actually really helpful. And so I had Saun-Toy help me out with finding other services once I transitioned out of my services with her, and that was helpful. But I will be honest and say that in general, services outside of mental health care are still very difficult to navigate. And I see a question in the chat about my journey with mental health care. I feel like what I would change would be, I think, seeking out other, sorry, I don't have my video on as well. I would seek out other diagnoses as well. I think now that I'm an adult, I realize that I am neurodivergent, and it's super important that I do kind of seek out getting assessed for that. And as an adult, that's very hard. As a person of color, that's very hard to seek out those assessments and diagnoses for someone who might have ADHD or autism. So I would really look into that. And that would be something I would really change as well. And I think there was another question as well about providers and doctors, and if I got adequate enough resources from them. I feel as if I did. Doctors and providers are doing the best that they can with the resources that they are provided. I think at the time when I was young, I felt very frustrated, especially on the housing front, about not having as many resources, or the resources just weren't accommodating enough to my situation. And so I had to do a lot of researching myself to see what I could find, and still very difficult. So I think I want to hold space as well to understand that providers are doing the best with the resources that they are given, that they can provide their patients, but there definitely can be a lot more support on that front. But there has to be institutional and systematic changes as well for providers to be able to do so.
Malia, thank you for your answer. And I hear you giving us a call to action that there are not enough mental health colleagues and therapists out there to support our community, and your souls and your spirit are just so very beautiful. I want to give voice to Tony's comments that transitioning from middle school to high school was really hard in terms of looking for services, and that there weren't enough therapists in her high school for all the students. As we think about this critical reflection and our shared path forward, we really do look to our youth and community, our system, and all of the leaders that are in our community. So now we're going to pivot, and we're going to hear from two extraordinary leaders within our city who are from Oakland Thrives. The first leader is Melanie Moore, and Melanie is the CEO of Oakland Thrives, which is a collective impact effort led by the City of Oakland, Alameda County, Oakland Unified School District, First Five, Oakland County Office of Education, the Peralta Community College District, and many, many community partners. Prior to being the CEO of Oakland Thrives, Melanie was the executive director of our beloved Golden State Warriors, their community foundation. Yay. And prior to that, she was executive director for All In Alameda and worked really closely with a hero in our community, late Supervisor Wilma Chan, to design and implement innovative solutions for issues that families are experiencing, particularly around poverty. Melanie will be joined by her colleague, Palak Shah, who really is tremendous. And Palak is a strategy consultant working with Oakland Thrives to support the child and adolescent behavioral health landscape analysis. And so I turn it over to you, Melanie and Palak. Thank you.
Thank you so much, Dana. We can go to the next slide. I really appreciate the chance to be here with all of you today. The timing is incredible because it's just today that we have released our landscape analysis report of child and adolescent behavioral health in Oakland and Alameda County. And we'll send a link to that for you in the chat. And what we wanted to do today is highlight some of our findings. First, I'll walk through a little bit about how we got to the landscape analysis report, what instigated it, what methodology we followed, and Palak will dive deeper into our findings around the current data, current needs and issues. The report concludes with findings and recommendations, and over the course of this three-part series, we very much hope that many of you on this call who are systems leaders and who are responsible for policies and programs in the area of child and adolescent behavioral health, that you will take up these recommendations and move into action, because of course we know that the sense of urgency couldn't be higher. We have to take action. We can't study this problem for another year. We need to figure out ways to solve issues that are facing our children and adolescents right away. So, but you know that, so that's why you're here. To share a little bit about Oakland Thrives, we are a collective impact organization. The way that we work is we listen. As Dr. Long pointed out, our stakeholders include our public sector systems, our city, county, schools, First Five, et cetera, as well as private sector partners such as Kaiser Permanente, UCSF Benioff Children's Hospital, Oakland, anchor institutions such as Unity Council, Ebaldsey, small nonprofit organizations such as Tribe, Street Level Health. So we talk to a range of stakeholders all the time and gather in various groups in conversation. We also attend a lot of other organizational meetings to really understand what's the pulse of Oakland right now in the areas of health, wealth, education, safety, and housing. Children and families are at the center of our work, and we know that all of those issue areas affect their everyday, and children and families don't experience any of those issues in a silo. So education isn't experienced as a separate world from healthcare, and that's not experienced as a separate world from the safety of their neighborhood or their access to groceries and what's for dinner tonight. And mental health and mental wellness also does not exist in a vacuum and in a separate silo. So as we talked with many of our participants and heard from our stakeholders, in early 2021, mental health was an issue that was growing in awareness. People were talking about it. If you remember back then, it's hard to remember where we are in terms of pandemic time, but students were still in Oakland, at least, in online school. And so we were anticipating what's going to happen when young people hit summer, what's going to happen when young people return to school in the fall. And mental and behavioral health was on the minds very much of young people, parents, practitioners, educators. So we organized a working group, which represented many of the stakeholders that you see here on the slide, and all of our public sector systems, to talk about, okay, well, if mental health is an issue, what is the shape of that issue? What are the needs? What's the data? And as we worked with that working group, we decided that what we need to do is create a landscape analysis. We need to look at the issue from all sides. We also need to look at our systems and understand, what are we currently doing? Where are the gaps? Where are the opportunities? And so that's what we did throughout most of 2021. And in the summer, we were able to start really pulling together data that we had gathered, interviews that we conducted with key stakeholders in many of your organizations, as well as a series of youth focus groups that we were able to conduct with nonprofits that are youth serving, some of which are also connected with our school-based health centers in Alameda County. As I'm sure you know, Alameda County and Oakland have a very robust system of school-based health centers in their high schools. And so fast forward to today, we released the report. And so it's a huge accomplishment to just sort of get anything across the finish line. But the timeliness is really incredible, because we're not simply lifting up the issue and saying this is important. We're saying, here's a path forward. Our systems leaders, our nonprofit organizations, our philanthropic community, we all have a role to play in going forward. So you're going to hear me say that a million times over this segment, as well as in our future convenings. And you're going to find me pestering you in email and inviting you to meetings, because we're serious about implementing these recommendations. And as you'll see as we go forward, and Palak will share, they span a range of types of actions. And so she'll share more about that. And thank you in particular to leaders from UCSF Benioff Children's Hospital, Matt Cook, as well as Dr. Dana Long, as well as Saun-Toy Trotter, in particular, 3 people who've really sort of helped shepherd this report forward. So much gratitude. And of course, they're only some of the people representing, only one of these institutions that you see on the screen. This has really been a collaborative effort. So I'm going to stop there and turn it over to Palak, who's done so much of the heavy lifting, thought work, writing of the report, digging through the data. And Palak has also conducted a landscape analysis on child and adolescent behavioral health for Marin County, and works closely with the Children's Trust. So I would love to say that she's only hours at Oakland Thrives, but she's not. She is her own scholar and researcher and expert. So you're in good hands. And Palak, thank you so much for walking us through some of the findings of the report.
Thank you, Melanie. Hi, everyone. I really appreciate you having us here today to talk about this landscape analysis, which we are so excited. I put the link in the chat. Please go take a look at it, share it far and wide. If you can go to the next slide, please. I won't belabor us with the data that we all know and understand and have seen. These are just a couple of snippets from the landscape analysis about these feelings of sadness and hopelessness that we're seeing with our youth. And of particular note, I wanted to show how it's ticked up in the last year, right? So we know it was on the rise prior to the pandemic, but we are seeing that tick up in the pandemic as well. It's higher for our gay, bisexual, and lesbian youth. It's higher for our multiracial youth. These are patterns we've seen in the past, and they're just being exacerbated by the pandemic. Next slide, please. I'm not, again, going to get too deep into this, but this shows how the pandemic has really exacerbated outcomes for our youth, mental health outcomes for our youth. I thought this graph was very, very interesting. What this looks at is mental health related emergency department visits for youth, I believe ages less than 18 years old. The solid line is 2019, and the dotted line is the same period, same period of time, but in 2020. So you can see from weeks 1 through 12, if you think of that as January through March, they're kind of aligned, the two lines. And then you see that gap forming, meaning in 2020 from April onward, as opposed to 2019, the visits are going up. So this is a clear indicator of what is happening for our youth as a result of the pandemic. Now, I want to say that this report and the analysis we've done and everything we talk about, these aren't the only data points that are important in terms of understanding what's going on for our youth. We have to acknowledge the social drivers of behavioral health and mental health. We have to acknowledge things outside of depression-related symptoms and emergency department visits, things like caregiver incarceration and neighborhood violence and physical neglect and abuse, a lot of the things that are happening around our youth that are leading to some of these. And the report, the landscape analysis, actually focuses quite a bit on those factors in terms of understanding what is going on for behavioral health for our youth. Can we go to the next slide, please? I want us all, I'm gonna get silent for a sec. I want us all to take a moment and just read this quote from a youth that was part of a focus group that we held. I'm going to read it now. When you are close with your friends, it's easier to share and you understand how to share with them. With a therapist, they ask questions, and sometimes I don't know how to respond because of the way they ask. It doesn't work when therapists just ask me what my problem is. So I want to first acknowledge that the work that our therapists and clinicians are doing is incredible. We heard earlier today, those relationships are really, really powerful. And something that came up as we were talking with stakeholders, as we partnered to run focus groups, was that we needed to build off of what was happening on the clinician side and on the clinical side, that we needed to build off of the strong communities and relationships that youth have in Oakland already to serve them from a behavioral health perspective. And so how do we foster strong relationships with our youth beyond just the clinical, right? And how do we build the clinical as well? So next slide, please. We partnered with Youth Alive. We partnered with community education partners, Tribe, Ever Forward Club, and EBASI to run a set of focus groups to talk to students, to middle and high schoolers about what was coming up for them around what assets they had, what coping mechanisms they had, what stressors. And these are the things that came up. The stressors that they were feeling, there was a lot around gun violence in their neighborhood, around not feeling safe due to gun violence, academic pressure of school, just the schoolwork load, bullying, racism, and childcare, really like caring for their siblings and being asked to care for their siblings, particularly during the pandemic, came up as a stressor for them. But we also heard they felt really safe at home with their family and their pets. They felt safe with their school counselors. These are the folks that they went to for support. This is where they felt heard. They coped with their stressors through art and music a lot of the time. These were the things they reached out to when they needed support with these stressors. A lot of them mentioned talking to their mothers, their sisters, their grandmothers. We noticed this pattern of matrilineal support that was going on with the students that were in these focus groups. And finally, when we asked them what sort of resources they wanted, they mentioned jobs. Interestingly, as a response to trauma or to stressors, students and youth are craving this sort of financial independence, independence in other ways as well, ways to meet people, I think, especially as a response to the pandemic. And you don't frequently hear jobs necessarily as something that is an approach or an intervention around behavioral health. Safe spaces as well, just spaces to actually speak in. One of the facilitators we partnered with for these focus groups, they mentioned that the space itself, bringing these youth together to actually talk to each other explicitly about their behavioral health, was cathartic in itself. And so these safe spaces actually are something, a resource that they want to cope with stressors. Next slide, please. So our landscape analysis came up with several different themes. And again, I don't think any of these will be brand new to anyone in this room. The first is just looking at the data that our youth are in crisis. It's particularly stark for our Black, our Latinx, and our LGBTQ+ youth. But we also have unprecedented funding opportunities, new policies from the state. This was mentioned as well earlier. I know this is something we're going to get deeper into in the second session of this UCSF HEAT series. So I'm really excited to explore that further with you all then. That non-clinical approaches, in addition to clinical approaches, hand in hand with clinical approaches, are powerful. That the therapist alongside the adult in the community that has the informal relationship with the youth, those hand in hand are what's powerful, especially in our communities in Oakland. And lastly, building that clinical workforce and supporting practitioners of color. We've been hearing about, this workforce shortage, the Great Resignation, everything across the board, and we're especially hearing it in healthcare settings, and particularly for practitioners of color. So thinking really mindfully about how we build up that clinical workforce, and in a way that has culturally congruent practices that's meeting youth where they are, is going to be really critical, and is a theme that came up as well in our work. Next slide, please. So I want to end by just touching lightly on the theory of change and the recommendations that have come out of our report. So a theory of change, the three areas where we're seeing a lot of programs already doing incredible work in Oakland, is around school and community cohesion, around family cohesion going beyond just spaces for families to safely congregate, but also how do we support families with economic supports, with basic needs, things like that. And then lastly, being able to support those youth that have severe needs, and also identifying those. So given that, I'm going to touch really lightly on our recommendations, but we will and want to go deeper on these when we're talking at later ones of these UCSF HEAT series sessions, when we get really into how are we bringing us all together to implement, as Melanie said, implement. She's going to be reaching out to you about some of these. So the first thing that really came up for us was around broadening how we define behavioral health. This is what I said earlier around, it's not just looking at feelings of depression, suicidal ideation, things like that, but how are we taking into account things like neighborhood violence when we think about behavioral health? How are we taking into account somatic symptoms that might come up? If a student comes in with a stomach ache, is that just a stomach ache, or are we really looking at that from a behavioral health perspective? The second, again, is go beyond the doctor and therapist. So the doctor and the therapist, very important. And how do we build on top of that in terms of some of these non-clinical approaches I've been talking about? And then the last is making it easier for youth and families to seek and for practitioners to provide clinical care. So as Melanie mentioned in the chat, the report goes into much more detail about these recommendations. And a lot of it is, we have recommendations based on sector and touching on the different parts of state policy and funding that we could leverage and take advantage of. But we hope to, Melanie and I hope to come back in a future one of these sessions to go more deeply on some of these recommendations. And I'm sure we will be reaching out to some of you to hit the ground running with these, with implementing these recommendations as well. So I am going to hand it back to Dr. Dana Long, I believe. Melanie, if you have anything to add, feel free. I'm also checking the chat for questions.
Thank you so much for walking us through your really complex and action-oriented landscape analysis. I do feel like it's a call to action, not only for our city, but a model that we should be scaling rapidly, as we know that our youth, our adolescents and youth are really struggling with their mental health, and that resiliency is out there. We need to figure out how to support it. So thank you so much. And if there are questions for Melanie and Palak, please put them in the chat and we will make time to make sure that we answer them. Thank you so much for the amazing work. I now want us to move us on to our next section. And the next section is on a shared vocabulary and definition for providers and advocates as we think about child and adolescent mental health. So for this session, we again have two amazing speakers. The first is Amy Whittle, and then Sabrina Fernandez. All of you guys know Amy and Sabrina for the most part, but I will take a minute to introduce them. So Amy Whittle is an associate clinical professor of pediatrics at UCSF, and she works at the Children's Health Center at Zuckerberg San Francisco General Hospital, where she's the associate medical director for integrated care, and she leads the physician and community and behavioral development rotations for our pediatric residency program. Sabrina is also a primary care pediatrician who cares for children of all ages, and Sabrina works at UCSF Benioff Children's Hospital. In her practice, she sees children for routine care, for health maintenance, and for sick and urgent care visits. And her main interests are preventative health care, quality improvement, and patient and physician communication. Sabrina is interested in medical education and is the Associate Program Director for Recruitment for the UCSF Pediatric Residency Program, as she enjoys mentoring and advising our upcoming physicians. So I'm first going to pass it to Amy and then Sabrina. Thank you so much.
Thank you, Dana. Thank you for having us. I'm so honored to be in this group and have learned a lot already. So I'm really grateful for this community. So I'm going to, in 10 minutes or so, try to give an overview of the Medi-Cal system when it comes to mental health. Clearly, this is going to be a very big picture overview, but we thought it would be really important to have just the basics when it comes to how the system is set up. You're going to see later a very complex map that this team has worked on, trying to delineate pathways that patients go down. And I think having the kind of pull back the curtain, get the foundation of what's happening at a systems level is going to be really helpful. So I'm going to talk about this divide between non-specialty and specialty mental health, briefly touch on structures around mental health services in schools. And I've highlighted particular vocabulary terms or acronyms, right? Just when we thought we'd learned enough acronyms, there's a whole lot more to learn when it comes to mental health systems in the state. Those will be in purple because that's my 3-year-old's favorite color. So next slide, please. All right, so the biggest divide to understand is this concept of non-specialty, which is a new-ish name. It used to be referred to as mild to moderate, versus specialty mental health care. So an acronym for you, MCPs or managed care plans. The vast majority of youth in the Medi-Cal system are getting their care through a managed care plan. And this varies by county. There could be a few to choose from. There could be multiples to choose from. Within your managed care plan, you have a PCP or primary care provider who is providing you care. I just want to take a step back. I know this is going to be very basic for some of you all, and some of you all are the absolute experts on this. So just recognize that we're kind of level setting. So that's the first system. The second system is the specialty mental health system, and that those are administered through the counties, and they're called MHPs or mental health plans. We usually, in our area, talk about them as being BHS in San Francisco, Behavioral Health Services, or in Alameda County, it's Behavioral Health Care Services, BHCS. And we have what's called a waiver to do this, which is a request to the federal government to administer the Medicaid benefit in a certain way. Just to point out that we are a vast majority of states to do it this way, to carve out the mental health benefit from your traditional managed care. And we're actually moving away from that through CalAIM. There's only about 8 states that do it this way. So yes, while it might seem that this is sort of an easy, okay, you might go down this pathway or you might go down that pathway, it's actually an unbelievably complex system. You can advance to the next graphic. I think those of us who have lived through this know it's very confusing about which system is responsible for what. And from the provider's perspective, from the patient's perspective, from the family's perspective, it can feel just incredibly complex. I recommend a 2019 California Children's Hospital Association report on improving mental health delivery systems. It compared the system to the Winchester Mystery House, where we don't really know which door is going to lead to what. But this is part of the hope and the promise of CalAIM and the no wrong door policy, so that no matter where you show up, you will be kind of directed to the care that you need. The next slide, please. So another very basic term, DHCS, the Department of Healthcare Services for the state. So this is under the umbrella of the Health and Human Services Agency. This is the entity that directs Medi-Cal and will be overseeing both the specialty and non-specialty branches of mental health. Okay, please advance to the next slide. All right, so let's talk a little bit about on the ground what it looks like to get non-specialty services. So in terms of how these are administered, it's about half and half across the state. About half of managed care plans are partnering with behavioral health management companies, and the one that we're probably all the most familiar with in this area is Beacon. And some managed care plans directly administer the mild to moderate, AKA non-specialty mental health benefit. In terms of just the logistics, the referral could come from the PCP, the primary care provider, or the family patient. And then the patient would be connected to contracted mental health providers through either this behavioral health management company or directly from the managed care plan. So at a practical level, I'm seeing a patient, I think they could benefit from these services. I can either have them call, for us it's Beacon for the majority of the patients that I see, or call Anthem, the other managed care plan that we work with. And they will be given either a list of providers to try to contact or a smaller grouping of providers. And they may qualify, they may be in a position to get case management around access to a mental health provider. And then it's sort of up to the family to follow through. The communication systems are very manual. There's no shared communication system back and forth. And we're going to get to, I've been alluding to this, like non-specialty versus specialty and the fact that the definitions have changed. We're going to get to that. But just generally speaking, it is a minority of the mental health services that the managed care plans hold. The vast majority of the responsibility for mental health services is through the county. So let's go to the next slide and talk about that system. Oh, and before we do that, I forgot there's one slide in between. Just to point out one other particular non-specialty mental health service that's related to children. You can advance the next slide. Children with most generally autism or intellectual disability. The therapy for behavioral health, it's a little confusing because it sounds really similar to other things that patients might qualify for, but behavioral health therapy is pertaining to a service that teaches skills with the use of behavioral observation reinforcement through prompting to teach each step of a targeted behavior. And I think the one that we're all the most familiar with is ABA, or Applied Behavioral Analysis. So if you hear that acronym, that's what that's about. This is administered through BCBAs, or Board Certified Behavioral Analysts, who supervise behavioral technicians. So again, at a practical level, I see a family whose child has a diagnosis of autism or another condition that I think could benefit from this behavioral health therapy. I fill out a specific form and fax that to either the MCP or the behavioral health management company. Let's take Beacon as an example. Beacon then has a group of vendors that it contracts with that provide that ABA. So they assign the case to one of those vendors who delivers the benefit. And so that's an example. So youth with developmental disabilities is an example of one of the kind of smaller grouping of mental health responsibilities that the managed care plans hold. Other examples would be mental health conditions that are a direct result of a physical condition, some med management responsibilities, screening responsibilities. But now let's move over to the specialty mental health world. So we can advance to the next slide. So again, this is a carve out. The counties hold this responsibility. You'll hear BHS or BHCS. And similarly, they contract with a network of organizations, including our own institution, to have contracts to provide a variety of mental health services. So everything from intensive inpatient to outpatient. It could be therapy, psychiatry visits, case management, crisis services. Probably most of you all know that this is a separate system in terms of the EMR or electronic medical record. I know it's really complicated as a primary care provider because the psychiatry notes are in a completely separate place. I have teenagers coming in to say, you know, I'm on this medication and then we switched it and it's, you know, this color pill. And it takes a lot of manual communication with the psychiatrist and to get that information shared between the systems. Also, just to point out that these systems are different between counties. So if you're a psychiatrist who works in multiple counties, you might have to get trained and credentialed in these different worlds. And they can be quite complex EMRs to navigate from what I've heard. And then referral, I mean, really to Saun-Toy's point about how her family member with a medical condition had a much easier time navigating. We can't just put in a referral through our EMRs to this system. We have to ask the family to either directly go to an organization that we know is contracted with the county or call the centralized access lines that are helping families to navigate to the right organization. I think we've all lived the fact that it is really hard to know who has capacity, which organizations have capacity that's specific to our patient's need and is going to be culturally responsive. So that's the specialty mental health system in a nutshell. And I mentioned the fact that there's confusion around who qualifies for what and that it's changing. So we're going to get to that. But just to recap, you can go to the next slide, please. I'm sorry. First, I want to show you some numbers. I think this is actually one of the most important slides that I'll show. This is from the report from just February this year, the DHCS Comprehensive Quality Strategy. And it's demonstrating that a little less than half of these specialty mental health services for children are happening for teenagers, 12 to 17. And, you know, consistently year over year, you can see the total number is 240,000 or so. This number represents fewer than 5% of children and youth enrolled in medical health. And that's only kind of one point of contact with the specialty system. If you look at 5 or more visits, it's more around 3% of beneficiaries accessing the benefit. And again, just to point out that the specialty system is responsible for the vast majority of mental health services that children are entitled to. All right, so let's move on to the next slide. This is the recap. The Medicaid benefit is administered through various silos. You'll see the second one is around dental services, and then the last one is around IHSS. But when it comes to the Medicaid benefit, when it comes to mental health, it's administered either through the managed care plans or through this specialty system, the county behavioral health agencies. Okay, so now let's get back to this issue of why or how we know which pathway patients are going to go down. And another important acronym to know on the next slide is EPSDT. So early periodic screening, diagnosis, and treatment. This is the federal government's definition of what children and youth are entitled to under Medicaid. And I used the word before, entitlement, really specifically. This is an uncapped entitlement. This definition is an advocate's best friend, right? This is a very broad definition. So Medicaid programs across the country are required to cover comprehensive screening, diagnosis, treatment, and preventative healthcare services, including behavioral health services, when they are necessary to correct or ameliorate any physical or behavioral conditions, or to prevent disease, disability, and other health conditions or their progression, to prolong life and to promote physical, mental health, and efficiency. So I really recommend a report by the National Health Law Program, the California Children's Trust, and the National Center for Youth Law, called Meeting the Moment, Understanding EPSDT and Improving Implementation in California to Address Growing Mental Health Needs. I didn't train in any of this formally. I just have been reading a lot and talking with a lot of people, and I found this to be one of the most helpful overviews of how this system works and what the opportunity is, knowing that we have this to back us up, right? We have the kind of intention behind what the Medicaid benefit should look like for youth. This is different than the adult definition, and this is part of what makes the system so darn confusing and tricky to navigate, is that this applies to the youth under 21, and the definition of what the county is responsible to provide to adults is different. It's less broad than this definition. Okay, I want to point out that sometimes this is used to sort of as shorthand to refer to specialty mental health and like BHCS. This is applying to all of Medicaid, actually. It actually applies to what you should be getting through your managed care plan, what you should be getting dental-wise, what you should be getting through your county mental health organization. But I think in some places, EPSDT is kind of used as shorthand for what mental health services the specialty or county system should be delivering. All right, so let's move on. So this is breaking news as of January 2022. The qualifications for specialty mental health changed to be more broad, and I think to really address some of what we've heard about already today, this idea that we know who's going to be at higher risk for mental health disorders, and that under that EPSDT standard, we really want to be preventative and comprehensive about who we're offering services to. So the first qualifying condition for specialty would be a condition placing a patient at high risk for a mental health disorder due to an experience of trauma. And that could be scoring high on a formal screening tool, i.e. the PEARLs, experiencing homelessness, being involved in the child welfare system, or being involved in the juvenile justice system. I mean, just to take a step back, that is huge, that you could be at high risk. You don't even have to have a diagnosis at this point, and you would still qualify. Or you have to meet both of these requirements. So you have a significant impairment or reasonable probability of a significant deterioration or of not progressing developmentally, and the condition is diagnosed or suspected to be a mental health disorder, or as a result of significant trauma, placing the patient at risk of a future mental health condition. So this is incredibly broad, and I think more in keeping with the EPSDT spirit of what Medicaid is meant to be delivering. Just to kind of contrast the language for adults, it's more around medical necessity, when it's reasonable and necessary to protect life, to prevent significant illness or significant disability, or to alleviate severe pain. So there's a lot more wording in the adult world around significant and severe. The child benefit is really much more broad in the county system. I do want to contrast that with the slide that we saw 2 or 3 earlier to show that currently fewer than 5% of beneficiaries benefit from the specialty system. So I think we've all lived the fact that we just have a whole lot more need than we have capacity at this point. All right, so that was my very quick overview. Let's move on to my next topic, mental health services in schools. It's easy for us in our siloed medical world to not have communication with schools. It's not easy. We have to get separate releases of information signed. We don't have easy email systems to navigate, but there is a lot going on around mental health services within the school community. And I just see them as a critical part of addressing this epidemic. It's a little tough to talk about this generically because each county is so different in how it partners with school, and even each school can be so different around what programs they're able to offer and how. But to move ahead to the next slide, just as an overview, this is from the California School-Based Health Alliance, and I also really recommend their website. They have put together a number of guides around financing of mental health in the school system. There's another report that I want to highlight called A Practical Guide for Financing Social, Emotional, and Mental Health in Schools that, again, the California Children's Trust and Breaking Barriers put out. And so to really break down what happens in the schools, Tier 1 refers to just school-wide preventative interventions, education. Tier 2 is more short-term targeted interventions. And then tier 3 is around longer-term intensive interventions. And you can see the kind of funding that's referenced on both sides of this. This could be a 2-hour lecture in itself to go through all of the nuances of this. And I do not claim to be an expert on it, but it is a complex system. There's one, so let's see the next slide. Actually, the next slide is an example of how SFUSD partners with BHS, again, the County Specialty Mental Health System, and the kinds of offerings that they provide. So the funding is really complicated in terms of who's doing what. I do want to highlight some of these. So an early childhood mental health consultation service, the wellness centers for all of the high schools in San Francisco, along with some elementary schools, and now middle schools are actually going to be coming online for wellness centers. In these kind of programs, specialty outpatient providers are embedded within the school. So for SFUSD, RAMS is one of their biggest partnerships. And I just want to point out in this bottom left corner, education-related mental health services. So this is the last kind of acronym that we're going to go over today. You can go to the next slide, please. So ERMS is an entitlement under the Individuals with Disability Education Act of 2004, the federal act. And the schools hold the responsibility for delivering mental health when it relates to the educational needs of a student with an IEP. So this could be a range of services, counseling, social work support, parent counseling, and even up to specialized classrooms or even specialized schools. So if you hear the term ERMS, that's what it's referring to. I'm going to stop there. Like I said, I hope this was kind of a view from 20,000 feet of our systems, and hopefully this will help orient you as we go through some of the more detailed maps later in our session. So now I'm going to turn this over to my friend and colleague, Sabrina Fernandez, who's going to talk about the private world, since all of that was only about children on Medicaid.
Thank you so much for having me, everybody. Similar to Dr. Whittle, I'm going to be going over really broad strokes of the private insurance mental health landscape, and I will qualify my comments by saying that I am one general pediatrician who's working in a large academic center, and a lot of my comments will be from my own personal experience, but hopefully will give you a good idea of big broad strokes of the complexities of the private insurance mental health landscape. Next slide. So I start off by just saying that similar to the world that Amy just went over, there's quite a lot of complexity, and you can just start by trying to name some of the private insurances that are available to our patients. And within each of these, there is also different plans and different coverage. And so the world is very difficult to keep track of because plans change or patients adjust across private insurances. So there's just a lot of options for people. Next slide. And so I'll say first that in terms of coverage, there's varied coverage there in terms of what exactly is offered by the private insurer. There's different referral requirements. I would say most places actually don't require a specific referral from the PCP, but some of my patients have asked for specific referrals. And that is not necessarily easily understood by primary care physicians or providers. And so we kind of have to be flexible with how we help patients access care. The cost to the patient really varies. So what exactly are they looking for? Are they looking for a neuropsych evaluation? Are they looking for a long-term supportive therapist? Are they looking for a CBT? All those things can cost different amounts. Maybe they have a different copay than another patient on a different insurance plan. And then in terms of how to access, it sounds very simple. You just look on the card and call the number. And that is one of those things that we probably encounter a lot that's much easier said than done. And so what typically happens to a patient is that their insurance provider will give them a list of mental health providers that are contracted with that specific insurance. And sometimes the list can be short and sometimes it can be quite long. And I've had many times the experience, and I'm sure this resonates with many folks on this call, that it just takes a lot of time and patience and follow-up. And me in my primary care role, I often will have patients follow up not too much later, a few weeks or a month later, and find that they made a bunch of phone calls, maybe got a few back that said that they weren't taking any patients, or maybe have something in the works. And so it really is a lot of work on the part of the family who may be in sort of a non-emergent mental health crisis in the family. And so I think any time that we're able to help with social worker support or other case management in our practices can be really meaningful for the family, to just help them, like, how is it going for you? Is there anything I can do to help move things along so that you can access care? I did want to also make everyone aware of a couple of resources. That's one of my goals today. And one of them is Psychology Today. Many people have probably heard of this, but it's a pretty useful website, I think, for the private insurance world, because you can vary by your insurance type, and you can also read a little bit about the provider that you're going to be seeing. And so I've had many mental health providers refer me to this website so that I can share it with patients, and they can do a little bit of their own research to try to filter through providers and find somebody that is taking on new patients. Next slide. I would say that another sort of layer of complexity is that there's lots of varied experiences with the mental health providers themselves. So first is the setting. So is it a one-on-one type setting? Is it a group setting? In those one-on-one or groups, the kind of therapy that is provided is different for every provider. Is there a parent involvement, or some kind of family support that can be given? Is there crisis support? Obviously different providers have different languages that they speak, different ages that they see. Some have very specific diagnoses that are their clinical area of expertise. And some of those can include some of the things that I'm sure everyone has also encountered too, especially eating disorders over the last couple of years. Looking for mental health providers that have that specialization has been a real need, in addition to LGBTQ, mental health, substance abuse, etc. Next slide. And then I did want to make a short aside, since the UCSF Benioff Children's Hospital San Francisco is the institution that I'm working at. I wanted to share a little bit of my experiences there. So a couple of things. The psychiatry and psychology group in San Francisco, Langley Porter, doesn't offer mental health services for patients with Medi-Cal and San Francisco Health Plan. I would say for any UCSF providers that are on the call, I would click around on the psychiatry referral itself. So even if you're not planning, even if your patient has Medi-Cal or San Francisco Health Plan, putting in the psychiatry referral itself and clicking around to the many dot phrases and branches within the referral may actually give you some resources that you weren't aware of. UCSF also offers child psychiatry e-consultations. And so those are for UCSF providers that want to ask a sort of specific physician to physician question that can help them manage the mental health need from a primary care standpoint. And a similar model that I will give a shout out to here as well is the Child and Adolescent Psychiatry Portal, or CAPP. that is a really wonderful group where it's slightly different than e-consultation in that you can get a peer-to-peer child psychiatry guidance over the phone, and so have a conversation and follow-up questions, whereas the e-consultation is mostly just a question in written form and then a single answer back. And for the CAPP group, they have enrolled many different practices, and UCSF is one of them, but I certainly recommend it for primary care providers who are wanting to have a little bit of better understanding of their psychiatry and needs for their patients, and want to try to manage some things on their own before referring out. Next slide. So I'll make a few comments about mental health crisis services before I hand it off. My job was mostly about the private insurance landscape, but I will say that for crisis services, it's pretty much the same. So of course, referring patients in an emergent crisis to 911 or to the emergency room. In the emergency room, there's the really wonderful comprehensive child crisis team that I'm sure many of you have worked with that can really help do safety screenings for our patients. And for those that are in non-emergent crisis, there are many hotlines. I cold call and did secret shopper to the suicide prevention hotline and found them to be really wonderful and supportive over the phone. Alameda's number is there as well. And then there are some other specific lifelines for patients as well that are available to them. And so that was my very broad strokes overview, but thank you so much for having me today, and I'll hand it back over to our moderators.
Thank you so much, Amy and Sabrina. As you can see, we purposely tapped two primary care physicians who have really gotten their hands dirty to understand just through their own practices and leadership in their clinics with the mental health system, and really just appreciate the breakdown of the complex system and terminology. I want to provide a little background on what emerged out of some work we were doing with the Social Needs Task Force. If you can go to the next slide. So as I mentioned earlier, the Social Needs Task Force started focusing on mental health approximately 9 months ago. And it became clear that one of the barriers to collaborating was that no one had a clear idea of what each site and non-mental health service area was doing to identify and address mental health needs. And so we brought in a wonderful health equity intern, Melanie, who's an MPH Berkeley student. We did over 20 focus interviews across different sites, services, and disciplines to ask people, like, what happens when a patient walks in and needs mental health needs? How do you identify that? And so if you go to the next slide, this is what the mental health map looks like. And again, just want to remind people that you're not supposed to read the details. I know you can't see that, but just visually, you can see how complicated it is. These are our notes in real time from the interviews. And when we clean this up, we will be able to share it, because there's actually I think, really interesting data in there and information in there, because we looked at, specialty clinics and primary care and ER and inpatient across our different sites. And yeah, it's so big that we had to break it up into 2 slides, but there were some commonalities across the sites and services, and one of the goals was people wanted to know, where can we share, what are points of collaboration, and so we created a general map, which I'll show in a second. But if you can go to the next slide, what occurred to us is that, and Brian King mentioned this when he saw it versus it looks like the house, the Winchester Mystery House in San Jose, where there's no official blueprint drawn up, and the architectural vision, there's no architectural vision, so things are just tacked on to the house. So there's staircases that go nowhere and doors that empty to nothing. And it's kind of like that with the mental health system. People are trying so hard and building things and programs, and but there's no coordination at the moment. or there are some, but not across the whole system. And I also was in reflection with Brian King in a conversation that, like, you know, there aren't too many other conditions we encounter where the algorithm for what happens to a patient looks like that map looks like. You know, we took a look at the asthma algorithm, it's a much more clear. And so it's no surprise that we as providers and also our patients feel like they're just in a maze a bit, and it's hard. So if you go to the next slide, we distilled what we heard and started to develop this generalized map because we really wanted to highlight, like, okay, so where are the green lights, the facilitators for patients and families and providers in navigating the system, and where are some of the barriers that we hopefully could try and address and see if we could turn those to like yellow or green lights. And so I'm going to actually risk sharing the Miro map that we created so I can walk you through it a little bit. It's oversimplified, and there are a lot of nuances that are captured on the larger map that we didn't capture here just because we needed to be able to show something that was simple enough that we could identify, use it as we walk through these series to possibly identify areas that we could collaborate and work on. So I will have you, yeah, I'll share my screen. Let's see if I can, 1 second. I'm gonna just make sure it's the thing that pops up. Okay. Do you see them? Do you see a map? Oh, like a? Are you seeing like a small little flow chart?
Yeah, we are, Anda. We're good.
Okay, great. So I'm going to zoom in. I know it's tiny. I'm going to zoom in here. So starting in the outpatient setting, I'm keeping an eye on time. We will share a link can be, if it's not already in the chat, Cassandra, could you put a link to the Miro map? So I'm calling out school behavioral health. Amy did a really wonderful overview. So, but we do not focus on school-based mental health services, even though we know it's a really important resource and partner. And we didn't take a deep dive into it. And we know that there's some model programs like those in Oakland. Those are generally not the norm of the experience, I would say, talking to providers. Most healthcare team members I spoke to don't really have a clear idea of when patients are receiving mental health services in schools and how to avoid duplication and coordinate services well for their patients. In general, universal screening is happening for mental health across all our sites and services, including specialty care, ER, inpatient, primary care, often using something like a validated screening tool like the PHQ 2 or 9, along with a lot of other possibly related, often related screeners like social determinants of health. If there's a positive screen, someone, often social worker or a nurse perhaps, or a behavioral health team member, if they are existing in the clinic, assess for severity and the need of services. And as Amy spoke about, mild to moderate, or now called non-specialty mental health or specialty mental health, and then there's a separate branch for crisis. So once that, a need is determined, the severity is determined, usually the question of insurance is next that comes up, private insurance versus Medi-Cal, and I'll just go down here in the non-specialty mental health realm. What we see generally at the end here, I'll just get to the end here with the roads are leading to these provider lists that we mentioned earlier. And so some of these lists come from the insurance providers. Some of these lists are clinical services have developed. Many of them have developed their own resource lists and provider lists. They are red lights in general because of the long waiting list, inaccurate availability often, and really the onus is on the patient and family to call each provider. It requires quite a bit of diligence. I'm going to go back up here because in the process of getting to that provider list, some clinics, and it can be really helpful if this exists, is this in-house bridge care. It's what I call in-house bridge care, and that some clinical services sites have developed ways to provide the capacity to support the mental health and behavioral health needs of patients in the clinic. The most common form, especially in primary care, is for a healthcare provider themselves to provide the support via frequent check-ins, medication initiation, and management in some cases if the providers are comfortable. And the capacity for non-mental health providers to provide bridge care is supported by this Green Light program, which we'll hear more about, called the Child Adolescent Psychiatry Portal, or CAPP, which is like a consultative model that Sabrina mentioned. In addition, there's a little box here called the Health Plan Site Consultation. I admittedly encountered that when I was looking at the health plan's algorithm for mental health or services for mental health. And this came up, but honestly, no one I spoke with talked about this. So I don't think it's known. And I also think it's probably largely adult focused. But I know our health plan colleagues will be joining us in some of the later sessions. And so there'll be something that'll be interesting to talk about. The other programs that have the clinics that have integrated behavioral health or very rarely psychiatry team members embedded. For example, the Brain Center Clinic for individuals with epilepsy has embedded psychiatry through philanthropic funding. So, and many of these bridge care in-house behavioral health integrated teams are funded through grants or sometimes through county or health plan contracts, like sometimes the behavioral health team is actually the beacon provider contracted through the county. So they're integrated in the clinic that way, and it creates some sustainability. And again, I think we'll hear an example of this later. So bridge care, is bridge care, only a certain number of sessions. And if the patient needs services beyond that, the team's working to identify outside services. Keeping an eye on time here. Which again, then we get into the whole challenge of trying to identify a provider, and we end up often, in these red areas. I just want to call out this other yellow box, which is care coordination, which a lot of clinics are striving to do, really overwhelmed, and a variety of clinics have different capacities to do this. But they also said that somewhere up above in the assessment time, that assessment of severity, often there's also an assessment of what the family's need is and goals are, and whether they actually need care coordination. So sometimes care coordination happens depending on what the family and patient need is, but that's delivered through either clinical social worker, behavioral health team member sometimes. There are health plan care coordination, but honestly that was minimally used or referenced by people. I think often it's just not in I don't know if that is an area perhaps that we need to leverage more. Also, often I think the coordinators are possibly more adult focused from our conversations. Okay, I think I'm going to stop there just in the interest of time, but I'll show you that on this map, we also have, specialty mental health. And you can see why I didn't do we were going to do one of those presentations that move around a lot and people are going to get very sick, I think. So specialty mental health, I'm just going to highlight that, as Amy mentioned, there's county mental health at the end, and for private insurance, often referrals to places like Langley Porter, which does not accept Medi-Cal, also has long waiting lists, unfortunately. And also our county mental health system also has waiting lists. There's an access line, which is kind of like a yellow light, what I call a yellow light. It's trying to provide some coordination, I think, or streamlining for patients. But again, the onus is often on the patients and family to call the line and then call the clinic that the access line tells them to call. And I think it is not always the smoothest process for our patients. And again, a lot of waiting lists. One last thing I'll call out is that some of our clinics or services are county mental health providers. So like at San Francisco, Zuckerberg San Francisco General, the child adolescent services are county mental health providers. And so we can do a direct referral to them. But again, there are waiting lists there too. So I will just, I think I'll stop there so that we can get to our break. But I will say that there's an inpatient algorithm as well, or not algorithm, sorry, mapping. And I'll just call out that it's wonderful that we have, I'm going to stop sharing, the behavioral emergency response team over in the East Bay, which I think they're going to replicate or working to replicate over in the West Bay as well. Okay, I'll stop there in the interest of time.
Thank you, thank you, thank you so much, Onda, for sharing the amazing mapping work that that you've been working on with the task force. And I want to give a shout out to Sabrina and Amy for giving us the overview of Medi-Cal and private insurance. I'm going to take some moderators' liberties here. And I'm going to ask Nikki Bush to come off of mute for 45 seconds and just share her reflections around what she's heard so far. And then we're going to get to the Q&A. So Nikki, do you want to come off mute for a minute?
Hi, can you hear me?
Mm-hmm.
First, just blown away by everyone being able to put all this stuff together, because obviously that's what people need. Even myself, I've been a part of UCSF since 2007, and having it laid out like this is really helpful to me, even though I kind of know it's really easy to get lost. And I think one of the challenges, on the leadership of both pediatrics and the Department of Psychiatry, and I'm struck constantly by how we can see one patient in one department and not the other, depending on their insurance background, and that can change really quickly depending on their what's going on in their lives, and how we have to find ways as a system to make this easier just for ourselves to understand and share patients and do integrated care, while simultaneously continuing to advocate for these big changes. Because this amazing change in the definition of eligibility has been profound, but we don't have enough services to meet this new influx of people who are now increasingly eligible. And then there's just not enough continuity of care and sharing of patients smoothly here at UCSF. So just thrilled and appreciative and ready to be part of the battle with all of you guys to make this easier.
Thank you so much. We have a number of questions, some of which are answered and some of which I just want to speak out loud so that we can all understand where our thoughts are lying. And so the first comment is from Michelle K, who was reflecting on the amazing work by Oakland Thrives. And Michelle's question or comment is that she was wondering if similar work is happening in San Francisco, and would really love to see the same type of rigor, data, and collective impact as the landscaping that happened in Oakland. And so I just want to give a shout out for all that amazing work as part of Oakland Thrives. The next question and comment was from Christina Benke, and asking about the diagnosis and having to have a psychiatric diagnosis, whether or not it's required for Medi-Cal patients to receive psychotherapy, and whether or not CPT codes are tied to psychiatric diagnosis, and how this affects the process. And I want to thank William Martinez for really chiming in and answering that question. And Will, if you want to come off mute for a second, your answer was essentially, yes, you need a diagnosis. Is that correct?
Yeah, it's a little bit more complicated than that. Yeah, I'm going to put on video, even though I haven't checked what I look like. It's a bit more complicated, and they're still trying to figure this out. They effectively put the cart before the horse, right? They set out these new changes in January, and the counties have no idea how to implement them, and they're starting to do so now. And we just got this directive that effectively, if we can use just any ICD-10 code, so a Z code, there's many Z codes that'll just cover like medical trauma in a broad sense. As long as we can use that, then we're good to go and we can see a patient, as long as they meet that functional impairment criteria.
Wonderful, thank you so much. I think that we need to rest our brains for a couple minutes as we launch into our next amazing panel, where we really look underneath the hood at programs that have been meeting gaps. We are going to take a 5-minute stretch break, everybody. Be back here at 2:55. Please stand up, get a glass of water, and we're really excited to highlight amazing programs that have been focused on equity, that have been serving the mental and behavioral health needs of our kids and adolescents. See you in 5 minutes. Welcome back. Time to put the glasses back on. And hello, we are in the home stretch. And I hope that everyone is feeling the heat of our session and understanding that there's so much connection that's happening across campuses and disciplines in order to figure out a very complicated system so that we can make sure that we are serving our patients and communities, that we're supporting each other, and that our youth are thriving. So I'm going to give everyone a minute to settle back into their chairs. As Saun-Toy taught me, I'm putting my feet on the ground, closing my eyes. Took a cleansing breath, and I am ready to go. So in our last session, we are really going to look underneath the hood and ground participants in what is happening within our systems. We wanted to spotlight specific programs that have really developed to fill the gaps, to help us to rise up and to meet the needs of our patients and communities. The programs that you're going to hear from really expand the capacity of non-mental health providers to support the mental health needs of our patients. I want to say that one more time because everyone appreciates how amazing our mental health colleagues are. Our behavioral health, our psychiatrists, therapists, psychologists, school counselors. We are so indebted to you and we love working with you. And what is also true is that we are not mental health trained providers. A lot of us are primary care physicians trying to meet these gaps and doing the best that we can. So we want to acknowledge all of the tremendous work of our mental health colleagues. And what you see now is us trying to figure out and to learn how to best support the mental health needs as primary care physicians, and we really rely on you. This next session is going to be like speed dating, right? It's going to be a panel of amazing, innovative leaders, and they are going to provide an overview of their programs. So we have 7 panelists, And what they're going to do is they're going to describe their program goals, why this program was created, activities, so how does the program achieve its goals? They will describe their target population so that we can know who should be referred to them. They will talk about how to access their program, their plans for program sustainability, as well as talk about one major challenge that is a barrier to the program success. I'm going to introduce you to the panelists now, and one panelist is going to be directly followed by another. So each panelist, after you are done, please hand it off to the next panelist. So our first panelist is Dr. Joan Jeung, who is the director of the Resiliency Clinic at UCSF Children's Hospital, Oakland. The next is Kate Margolis, who's the director of the Division of Integrated Behavioral Health. And she'll give an overview of the HealthySteps program that is currently being implemented at the Children's Health Center at San Francisco General. We're going to hear from Marina Franco, who is medical school bound, but currently one of our FINDconnect, so FIND is the Family Information and Navigation Desk navigators at UCSF Children's Hospital, Oakland. Next will be Petra Steinbuchel, who is the director of the UCSF Children's Hospital Child and Adolescent Psychiatry Portal, aka CAPP. Followed by Saun-Toy Trotter, the program manager for our school-based behavioral health program. And the last but not least panelist is Maggie Del Cid, director of the Family Mental Health Navigation Program at San Francisco General. So each panelist will be spotlighted one by one. And Joanne, we're going to start with you.
Thank you so much, Dana, for that introduction. Next slide, please. So I direct this program called the Resiliency Clinic, and currently it's available at the Federally Qualified Health Center or the Primary Care Clinic at Benioff Children's Hospital, Oakland. And as you know, the Oakland Clinic really helps to develop the PEARLS tool for screening for adverse childhood experiences. And one of the first questions we always get is, okay, so if they screen positive for one of these ACEs, what do you then do? How do you respond to the family? And this program, the Resiliency Clinic, was part of the response to that question. And so this program currently provides interactive groups, both for caregivers and their children, who are referred by their primary care physicians after they screen positive for one of the ACEs on the PEARLS screen. And we offer these interactive groups for both the caregivers and their kids to come to at the same time, to basically learn a lot of tools for promoting resilience in themselves and their families and children, and to strengthen that connection between parents and their children. Next slide, please. So our curriculum really drives from two sources. One is this evidence-based parenting support program called Circle of Security Parenting. And this has been implemented across the United States and internationally as well. It was developed and tested actually largely out of Head Start programs. So really targeted towards a young audience, 0 to 5, as well as a diverse one. And it's really geared towards, again, strengthening that connection between parents and their children, helping parents to understand the cues that their kids are giving them through their behavior, to respond appropriately, and I think very importantly, to understand, for parents to understand like how their own childhood experiences might be affecting their present day parenting. We're also deriving some mindfulness-based materials from Dovetail Learning, and they have a program called We Are Resilient, which they develop specifically for healthcare and for primary care providers. Develop our own resilience to help strengthen our own mindful practices, as well as to have some anticipatory guidance to provide to parents. And we work very closely with Dovetail in adapting some of their materials for our parents in the Resiliency Clinic. The whole idea behind this, and I want to put out this phrase, is promoting self-regulation and co-regulation, because young children really need the help of the adults around them to understand, name, and to regulate those big feelings. And that in turn takes a lot of work in self-regulation on the part of parents. And so this dance of self-regulation and co-regulation, which in turn helps children to learn that self-regulation, is really the crux of what Resiliency Clinic is about. Next slide, please. So a couple of nuts and bolts. We meet for 6 weeks in a row. Previously, we met in a room upstairs in the primary care clinic, but these days we're on Zoom. Our sessions last for about an hour and a half each. They're facilitated by either a licensed clinical social worker or a marriage and family therapist. So it's really anchored by our behavioral health colleagues, but co-facilitated by a pediatrician or by pediatric nurse practitioner with some outreach help from and help in leading some child activities from our community health workers or community health specialists or health educators. And the involvement of the medical professional largely revolves not only around co-facilitating the group, but also doing these brief medical visits or brief one-on-one check-ins with each parent. And we actually bill those encounters. And that billable medical visit is what allows this model to become sustainable over the long term. So this is a group medical visit model. It's been piloted much more widely in the family medicine world than it has within pediatrics, but we've successfully billed for a lot of these visits for the last year and a half, and we're proof in concept that this might be sustainable. Next slide, please. So before each round of groups, one of our staff, usually one of our community health workers or our social worker or family therapist, will actually go out and do home visits for each of the families who sign up. And we deliver these care packages. And what's in it, like some of the things you see here on the slide. We've got the binder with a lot of resources inside. We've got books that help to name and understand emotions. Some stress relief tools, including bubbles, which are a great way to teach deep breathing to kids, glitter jars that are unbreakable, these stress balls. But the parents have told us this is actually a really key part of the program for them. And the kids will bring out books and show their parents that they remember this, or will put those glitter jars into their backpacks to take them to school. These are well used and an important part of the intervention. Slide, please. Next slide, please. And we don't have time to share this video, but this is a video called Just Breathe, and it's by Julie and Josh Salzman, and available by YouTube, and the link is in our slides, so you can take a look at this later. But we show this as one of our parent-child activities that they do jointly. And our 4 and 5-year-olds have learned deep breathing because it's kids in this video who are showing them this is why deep breathing is so important, and this is how you do it. And the parents tell us, the kids remind them. So the kids will remind their parents, just breathe, mommy, when their mommies need that reminder. With that, I will pass the mic over to Margolis.
Thank you, Joanne. And thank you so much for allowing me the opportunity to highlight one of our ZSFG programs. Before I begin, I just want to acknowledge that I come to this today standing on the shoulder of many giants, many of whom are based right at ZSFG and on this call, and have really helped to create the fertile ground that have allowed for the growth of the program that I will be talking about. I'm also pleased to say that the services I'll be talking about are actually now majority reimbursable for children who are served by Medi-Cal, and I'll talk a little bit about that at the end. So I'm going to share about our HealthySteps program, which is an evidence-based program that's used for pediatric primary care. And it provides an infrastructure for integrating family-centered clinical supports for children ages birth to 5. I'm struck by the number that Amy shared of less than 5% of all kids accessing specialty mental health. And within that, only 12% of those kids were 0 to 5. So we're talking about an enormous opportunity to serve young children within the primary care setting with preventative behavioral health services. We are the Children's Health Center, which is an FQHC at ZSFG, and we provide about 32,000 annual visits. And our HealthySteps program started about 3 years ago with grant funding from the Stupski Foundation. Next slide, please. The secret sauce of an early childhood integrated behavioral health program like HealthySteps is capitalizing on the power of well child visits. We do this by integrating a behavioral health clinician called a HealthySteps specialist into the pediatric healthcare team. In pediatric primary care, folks are already coming in for preventative services for things like vaccines, a protective and preventative mechanism. So we leverage this culture to introduce behavioral health in a non-stigmatizing way. We talk about social emotional inoculation as the reason for why you would meet with a HealthySteps specialist before a problem even exists. And this is really key, before the problem exists. So as it relates to health equity, this is about fundamentally changing the way that our behavioral health system provides support to families, supporting them when they're asking for help before the problems are so entrenched that the developmental trajectory towards illness is already well established. And there's 12 to 13 visits in the first 3 years of life. This provides an unparalleled opportunity to meet families in a setting that they already trust to provide a health equity promoting intervention in partnership with the families themselves. Next slide. And we're going to skip this one for time. Thank you, Cassandra. This is the HealthySteps model. This is the tiered structure that the model provides, and it is a population-based service for all children ages 0 to 3, tailoring services to the family's level of need. At our clinic, we've expanded this to preschoolers to include 4 and 5-year-olds as well. All children in the practice receive Tier 1 supports, the universal screening for child development, social emotional concerns, family needs like caregiver mental health. And then depending on the needs identified via the evidence-based screening tools, a portion of the clinic's population is triaged to receive either Tier 2, short-term consultation services for families' concerns, development, behavior, or Tier 3 comprehensive supports, where you actually have a HealthySteps specialist going into the well child visit from the time as early as possible, even the newborn visit, until the child turns 5 years old, joining every single well child visit. Next slide, please. One task of the HealthySteps specialist is to expand the focus of the pediatric visit to the child's environmental context. So this includes caregiver mental health, community health, and in the process of doing so, the way in which the practice provides care for the child begins to transform, and families become more active partners in their child's care experience. Next slide. So this slide highlights some of the ways in which we shift the focus from the individual pediatric patient to environmental well-being as a way to promote early relational health. One example of a typical activity at a 4-month visit is vaccines. So many of us may be familiar with the concept of the buffering caregiver as a way to mitigate toxic stress. One way that we might elicit a caregiver's competence as it relates to being that buffer is to say something like, shots can be tough for parents. How has it been for you to comfort your baby when they're in pain? And as you can see, this helps us to start a conversation about their critical role as a buffer against stress and to work with them to provide guidance on how this can be done. Next slide, please. So here I've listed the qualifications of HealthySteps providers. In our clinic, we have our providers are an LCSW, an LMFT, and psychologists, all in smaller portions of FTE. We typically see HealthySteps services stratified as shown. So if there's 2,000 patients in a practice, 200 of them might be triaged to Tier 2 and another 200 to Tier 3. This allowed us to serve over 1,200 patients last year, ages 0 to 5. And then in terms of sustainability on the next slide, so our program is currently philanthropically funded, as I've noted, but because of recent innovations at Medi-Cal, we can now bill for child behavioral health services in primary care when the child does not have a DSM diagnosis. We'll talk more about this in another session, but this is allowing us to plan for moving off of grant funding in the next fiscal year. And finally, on barriers, on the next slide, there's been great strides related to payment reform. The biggest programmatic barriers really remain the fragmentation of systems across the early childhood network of care, thinking about early intervention, childcare, pediatric settings, to name a few. And then also the fact that community health workers, peer specialists are still not billable providers. And so we've struggled to provide high quality navigation services to mitigate the fragmentation in the network of care, because there's not a way for those services to get paid for. We're hopeful that that will change, but that is currently the case. Thank you. And I will pass to FINDconnect to Marina, I believe. Thank you.
Thank you. Hi, everyone. My name is Marina, and I am a health education coordinator and an on-site Find navigator at the primary care clinic that's located on Claremont Avenue in Oakland. And I'm going to briefly tell you about the FINDconnect program. Next slide, please. FIND stands for Family Information and Navigation Desk. The primary care clinic has a designated desk and area for navigators to research, print, and help families connect to resources. The mission of our program is to reduce health inequities by partnering with families to reduce social drivers of health. We engage with, acknowledge, and mitigate these factors in order to achieve health equity for all children. We define health equity as all children having their basic needs met in order to reach optimum potential. Find hopes to make connecting with resources for social and environmental determinants of health easy and effective for all. We are able to do this with the help of our online platform, FINDconnect. On this platform, we have various screenings, such as the needs assessment, which enables the navigators to screen the guardian of the patient for social determinants of health that present barriers to health. The screening tool will prompt the guardians to identify any concerns regarding food insecurity, housing instability, activities for their children, assistance with utilities, healthcare, and other related areas. Through FINDconnect, navigators are prompted to ask additional questions and then obtain further details about their specific needs. After the screening is completed, the navigator is able to create an action plan. We are able to create a list of resources that both the navigators and family believe will best serve the identified needs. Thanks to the help of our extensive knowledge base, navigators are able to identify resources by category and proximity to the family's residence. In the event that the database does not contain resources that are appropriate for a family's needs, navigators will research the resource further by searching online and calling directly to obtain additional information. New resources are constantly being added and updated by navigators and program staff. Lastly, we create the action plan and establish follow-up timelines. Navigators create an individualized action plan and review the resources and information with the family. Why the resources were chosen and what kind of services will benefit the family will be discussed. Although all of this information is included in the action plan, it's important to verbally review the plan to field any questions or concerns, adjusting the resources as necessary, and clarify the next steps for the family and the navigator moving forward. Next slide, please. This map is showing you all of the geographical areas FIND has connected with for the year 2020 to 2022. The map is interactive and lets you move around to see other affected areas. We have had some hotspots as far away as Sacramento, Stockton, and Winters. Opportunities for growth include the onboarding of more navigators in order to increase contribution and connection between healthcare workers and our patients and the community. Onboarding navigators will increase access, collaboration, and resources within the FINDconnect program, all of which are factors that will directly support our goal of promoting and achieving health equity. And with that, I will pass it on to the next amazing program. Thank you.
Hi there, I'm Petra Steinbuchel. It's nice to see so many familiar faces. And I'm going to just walk us through a brief overview of the Child and Adolescent Psychiatry Portal that Sabrina had mentioned before, which is a pediatric mental health care access program that, that has been designed to really provide workforce development and improve pediatricians and pediatric primary care providers' knowledge, skills, and confidence in starting to manage mental health conditions. Next slide, please. So this is the idea behind it, really to help support workforce development within the medical home. And this is intended to be consistent with the American Academy of Pediatrics medical home model that's accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective, and that it's easy for the child and family to obtain, including geographic access and insurance accommodations. And as we've heard in the extensive mapping and presentations, that is not always so easy. So the idea with this is that, as has been shown in some of the other models, that pediatric primary care providers provide care for many patients in this tier 1, the bottom dark blue part of the pyramid, and that because of the limited number of specialists, that we try to reserve those specialty mental health spots for the most acute and complex presentations. And there is a lot of room in between in these areas 2, 3, and 4, where pediatricians together with therapists can manage some of the what might be classified in the mild to moderate category previously within primary care still. Next slide. So these types of programs are hub-based models that have been around actually for quite some time. And there was a 2019 RAND analysis that found that states that had these types of programs iteratively increased access to necessary mental health care. And the three key components are meant to be real-time consultation, as well as providing educational offerings and also support with resource referrals and care coordination. And HRSA has really gotten behind this and funded a lot of states' programs. Next slide. So our kind of main components, we have our initial CAPP consultation that is together with a psychiatrist, and that is generally by phone. And that's available Monday through Friday during regular business hours. We also offer a Reach Out and Connect psychologist consultation that is directly with families. And this is a way to get more kind of intensive specialized parent guidance and helping navigating triaging which problem to address first. And then we're also offering now bridge care coordination that is intended to be not necessarily for everyone, because we do provide a list of resources and referrals in our initial CAPP consultation, but for those families who seem to fall into a kind of higher tier 2 category and may have additional difficulties with navigating services. And that could be for, language reasons or knowledge reasons or, just multiple failed attempts in trying to navigate the system and access care. And so Marielle Ramsey is our Spanish speaking LCSW care coordinator. Next slide. This is just an overview of our training offerings that have been led by Dr. Joan Jeung, who has been spearheading our educational efforts. And these have included Project ECHO, which is a near-peer telementoring model that is about moving knowledge and not people, so developing expertise in the hands of many. And also our monthly webinars that are on a number of topics that are informed by the consultation questions that we receive. And then we still have our ACEs Aware Core training that is available for asynchronous viewing and CME and MOC credit on our website. Next slide. And just in review, so since we started in 2019, it really feels like we couldn't have come at a better time, because with the shift to more telehealth workflows and also with so much increased demand across the board, we've really been able to grow quite a bit. And we have delivered over 1,600 consults now. And we have over 1,000 primary care providers enrolled across 28 Northern California counties. And we are looking to expand our school consultation pilot that we've been doing in collaboration with Saun-Toy, Trotter, and others in the Bay Area. And with that, hopefully increasing access to care. And with that, I'm going to turn it over to Saun-Toy. Thank you.
Thank you, Petra. I'm just so honored to be part of such amazing behavioral health department and programs across our whole system. And I will be sharing with you a little bit about our school-based programs. So next slide, please. So our school-based programs are a health equity strategy that works. What we do is bring quality healthcare, behavioral health care, health education, and primary care to students, to children where they spend most of their time at schools. I will just share about our services by sharing two brief stories. One is there was a young person a couple months ago who told her teacher that she wanted to see a therapist. And she also spoke about having some risk, some thought about harming herself. And because there was a safety concern, we were able to meet with her that same day. And in that meeting, she shared that she had done therapy in the past, but this time she wanted to do it for herself, that she felt like she was forced to do it before, and that she did endorse having suicidal thoughts and thoughts of self-injury. And so we were able to do an intake, do a safety plan, and connect her with a therapist that spoke the same language as her parents and also shared some cultural similarities. In fact, the therapist that she got referred to was an alumni of the high school that the student went to. And so that's one example of, our school-based behavioral health services And the second example that I want to share is there was a young person who was murdered during this year. And the school reached out and we were able to provide a grief process for a class that the student was a part of and facilitate that for students and for staff. And in addition to then seeing if there are any young people who needed additional mental health services, we are providing consultation to the school to develop what we're calling Marcella's plan in her honor, in order to make sure that any young person who enters the school with high risk factors is connected, is screened, is provided services, is really wrapped around, especially students who enter school mid-year. So that's, two different examples of the services that we provide. Next slide, please. So overall, we provide individual and family therapy, and I would say, adolescent focus, culturally responsive and aligned, evidence-based mental health services. We also partner with our psychiatry department and have psychiatric nurse practitioners who provide medical evaluation, assessment, consultation, and care. We have built our capacity to provide DBT skills group, and just so proud of our clinical team who have really taken on providing culturally responsive DBT groups. So for example, we developed a DBT group specifically for African-American transitional age youth called Flawless, and developed that actually through telehealth. And also our clinical team developed a DBT group in Espanol to be able to provide for students. One of our schools definitely has a large, significant recent immigrant youth newcomer population. We also have the Resilient Teens program, which is modeled after the Resiliency Clinic in primary care, which has medical social workers who provide free therapy, as well as medical social work and pro screening. And we provide mental health consultation. And so that can look anything from training and consultation to teachers, or even we are currently providing kind of weekly consultation to school administrators and leaders with a trauma-informed lens. And really, as they hold the school, the teachers, educators, and students, being able to use that reflective time in their practices. And then outreach and education. And I think the one program I do want to lift up is Mindful Mondays. As students were returning back to school, one of our clinicians thought about, how do we really support young people to advocate for themselves, as you heard Malia say earlier, to advocate and ask for services, to really understand what is therapy, what does this mean? And Ebony Ellis, along with some of her colleagues, created a Mindful Monday curriculum around what is therapy, helping young people understand depression, anxiety, trauma. Why might you refer yourself? And that is being taught in the schools in collaboration with some of the classes. For referrals for our program, referrals come from what's called COS, a Coordination of Services team, which is a team that sits at the school, including school-based administrators, behavioral health providers. So we are not the only behavioral health provider connected to our schools. There are sometimes other providers and substance abuse providers. And so we think through those referrals. Do they need a mental health referral? Do they need a referral to a doctor? Do they need a referral to Soccer's Without Borders? Or do they need a referral to the food pantry or to after school program, right? So we think together and provide consultation and guidance around those referrals. And we also get referrals from our school-based health center providers and teen clinics. And sometimes we're able to open up to primary care because we are located on and next to school campuses, but we serve the full community. So young people who live in East Oakland and West Oakland are also eligible for our school-based behavioral health services. Next slide, please. How we're funded, and I want to acknowledge Kristen Zimmerman for this image, who she actually volunteered and created this image for How Are You Healing? Grief and Healing Day at McClymonds High School a few years ago that we had with students in the community there. And we're funded primarily through Alameda County EPSCT Medi-Cal. Again, thank you so much for Dr. Amy for sharing about that. there are opportunities and so many barriers to the EPSCT Medi-Cal, including being at a school campus. We have many young people who might self-refer, who might need services, who may not have full scope Medi-Cal or have limited access to insurance. I'm hopeful with the new changes with CalAIM that we'll be able to see more young people, but our funding is through Medi-Cal with Alameda County. And then we have the generous and partnership of private donors and family foundations, including Dr. Dick Nagel, who's been a longtime supporter to support our work to be able to provide services to any young person who presents with risk of suicide. Also the Pritzker and Family Foundation and Sarlo Foundation, which is supporting our Resilient Teens work, FIND navigation, as well as medical social work and brief therapy, and many others. We also have, actually I want to just name in terms of funding, one last thing is, many funders that actually contributed to support staff wellness and well-being. And so we do have a Healing the Healer funds for our staff as well. And I am going to pass it to Dr. Maggie Del Cid for the Family Mental Health Navigation Program.
Thank you so much for that. That was really interesting. Hi, everyone. So I'm going to talk to you about our Family Mental Health Navigation Program that is based in the Children's Health Center in San Francisco General Hospital. This program was developed out of the need for reducing barriers that prevent publicly insured youth from finding, accessing, and engaging in mental health care treatment. So, the way that we've approached navigation is looking at this process of linking to specialty mental health services as a continuum. There's various phases of that lead up to linkage, and in those phases, there's various opportunities or sometimes times in which families could potentially get lost in the cracks. So we kind of use this cascade of care framework to really kind of map out, what does this linkage look like, and what are ways that our mental health navigators can help families maintain engagement so that they can ultimately connect to mental health care, as well as maintain stay in therapy and treatment once they are connected. Next phase. So in development, the next slide, please. In developing the program, what we did is we had to know where to start. So we really wanted to talk to the people that, the stakeholders that are referring kids to specialty mental health services or actually providing these services in the county. So we held interviews, focus groups with community-based organizations, mental community clinics, primary care providers here at the General, as well as behavioral health clinicians, all just to understand, what are the barriers they face when they're trying to connect families to care, as well as, what sort of support could the navigator provide for them, given their role in the continuum of care. So from all of that feedback, and I don't think I mentioned, we also spoke with families of youth who've been identified as needing specialty mental health services. That way we could, understand their unique needs and make sure that our navigation services could really support them with linkage. So what came out of those interviews is development of a 6-month program. So families who are seen in our pediatrics department at Zuckerberg, San Francisco General, are paired with a navigator. So either BA level or master's level staff, non-clinical staff person. And basically this navigator walks the family through the process of getting linked to mental health services. The navigator helps with communicating with the rest of their care team, so their primary care provider and any other people who are involved with behavioral health related services for the child. And also the navigator is providing a orientation to the family about the mental health care system. So allowing them to, get familiar with, what to expect, and also start thinking about, what are their expectations for therapy? What questions do they have? And what are they hoping, to get from the treatment? It's a great opportunity for them to have these answers in mind. So when they get connected to services, they're able to relate kind of what they're hoping to get out of therapy and communicate that with their therapist. Also, the navigators are helping problem solve when engagement issues come up, when there are problems with, finding an appropriate clinic to provide services. The navigator is there to help troubleshoot, not just with the families, but also with providers. The population that this program serves right now are publicly insured youth ages 6 to 7 who are identified as needing specialty mental health services in San Francisco County. And currently, these are patients who are seen at ZSFG. The way that families get access to this program is they're either referred by their PCP or a behavioral health, a member of a behavioral health team. As far as funding, there's 2 lines of funding that support this program. One is private foundation funding, so Presidio Giving Circle that has funded research on the program. So we want to see if it works and provide data to show that it works and how it works. So that's being funded through them. And then the clinical services piece is funded through Medi-Cal funding through Child, Youth, and Family Behavioral Health Services contract. Our hope is to have the research support more funding in the future. So if we see that this navigation model is effective, then that'll provide the leverage, hopefully, for more funding and either looking at a fee-for-service model in the future or actually something a bit more flexible to provide this type of care. And one of the major challenges, so we've already talked about many barriers to access, but particular to our program, something that we've noticed is, it's really hard to know exactly what services are available, how long it's going to take to connect to services. Right now, wait lists are the waits are approximated. We don't actually know how long it's going to take from referral to actual first appointment. So having a centralized system in which you're tracking this information would be really helpful. So I'll pass it to Dana now. Thank you all.
I want to give a big thanks to all of our panelists, and I have a few questions for each of you. So we're going to spotlight all of everybody. So Joanne, Kate, Petra, Saun-Toy, Maggie, and Marina. And if we can just sort of go through these questions just based off of sort of top of mind. The first question is for Joanne and Marina. And my question is, what are the biggest successes, like the biggest roses of your program? And what's your greatest thorn or the challenge that your program is currently having?
I guess I can start. So biggest successes, it's like whenever I hear from parents, like how the program has actually helped them. It's reduced their stress. They feel better. They feel more supported. They feel a little bit more confident. And I'm always impressed by how much our parents are carrying and how much our families are carrying and what it takes to show up and to be part of a group that can help hold them and provide a bit of a safe space is just amazing. And I'm especially happy when I hear about kids basically telling their parents, just breathe, mommy, or bringing out the books, that we bring. It's like, here, mommy, it's amazing to hear even young children being able to take and use and make use of some tools that are actually helping them as well. So that to me is like the biggest, like kind of like rose. I think the thorns, I think are really, I don't know if, even though this is free and this is in primary care and this is on Zoom, I think there's ways to go in figuring out how do we really make this accessible to families and make this something that doesn't feel like one more overwhelming thing to add to like a very crowded plate. Like a 6-week program that they're investing a lot into, you know, I'm still trying to figure out how do we actually make this more accessible.
For the FIND program, I would say that one of my biggest roses is just getting feedback from the family about getting enrolled into the outside programs such as like CalFresh, and actually I helped a family enroll in the Oakland Thrives families. So, you know, it was like a lottery where families get chosen to get $500 a month, and I helped a single mom with 3 kids. She's only been here 2 years from Ethiopia, and she had, you know, she was telling me that she just really needed a community. She didn't really know that many people. She just really wanted help. So we went through the whole application together, and she got it. And she was so, so happy. And, you know, I still think about her to this day. We still keep in touch. And so it's the success stories for us at FIND. One of the biggest thorns, I would say, is, like Joan said, you know, this is a free program, and you know, kind of like the funding comes from grants. And so if we're able to have kind of like that stability to kind of permanently have our foothold in that clinic and making sure that these families are always going to have access to this program, it would be so comforting, not only to the families, but also to the providers and to the clinic as a team, the social workers, the mental health providers, because we're part of that team too, and collaborating, it creates, you know, success stories.
Thank you so much, Marina. My next question can be for any of the panelists, and it's related to the topic of today's session around clinical reflection and a shared step forward. Understanding the great amount of need that we have in our community for mental and behavioral health. You've heard this from our youth speakers. You heard this from Oakland Thrives. You saw this from the maps that Onda showed. And when thinking about these amazing programs, of which you are all innovators and leaders, right? How is it that we can have innovative programs, a real commitment and desire, and yet there's so much need? How do we meet those gaps?
I'll jump in. I think one of the things, you know, especially working in schools, you heard Tony speak about we need more therapists in schools, and students had said that. And, you know, that's just one part of the solution. It is part of the solution, but it's one, culturally responsive, you know, qualified clinicians. But I think the other part of the solution is building the capacity of the adults that are connected to young people. So building the capacity of teachers and educators, not to be therapists, but to navigate, you know, emotional health well-being, to model, to build that for themselves. Building the capacity of parents, of caregivers, of aunties and uncles and other people in the community, right? It's, you know, we can't have 100 therapists, you know, the school has 800, the school next door to me has 800 students. You know, we can't have a therapist for every student, but we can build an emotional healing, skillful, intelligent environment in the schools or in someone's home. So a lot of the consultation capacity building that you hear that CAPP does and some of the other programs you heard, I think that's a very important part of the solution.
Just to dovetail on that Saun-Toy said so eloquently, I think, you know, also shifting from just a kind of a more binary, you know, approach to things of there's pathology or there's not pathology, and I need a therapist or I don't need a therapist, but really thinking about how can we elevate everyone's mental health literacy and, you know, management strategies, and also how can we build a culture of wellness and support and think about embedding that kind of from the beginning. And part of that, a really key part of that, I think, is being connected, connected within our systems of care, connected within our communities, within our families. And, and a lot of baby steps can add up in that regard.
Thank you for the question, Dana. I think there's so many ways to respond to this, but something that I've been thinking a lot about is we have so many frontline practitioners, licensed, unlicensed, and families who have so much experience to share. And I think that something that we don't see that really is contributing to burnout is our providers, our staff do not have protected time to think about how to administer, how to learn the policy. Amy Whittle presented this incredibly complex system of care that honestly is like a full-time job to learn how to navigate. And that is what is required in order to leverage and sustain successful programs. And I think that we are in some way failing our trainees by not teaching them how to do that and all of these nuts and bolts. I think it's a really, really important piece to be able to protect the time to sustain our workforce, but also learn how to be successful in a sustainable service model.
I agree with all of that. And what I'm hoping is becoming apparent is that this session is about us all thinking together, right? Like we need to be able to work towards having this roadmap for UCSF, for the Department of Peds, about how we are better addressing community needs and supporting ourselves as providers. So in hopes that we can create that roadmap, we really want to engage you all continuously and to build on this session. I'm going to hand it over to Anda to talk about our next activity, and then we're going to close out and let you know about what's next.
Okay, thank you. Thank you so much. What inspiring cluster of programs we learned about, and there's so many more out there too. And as we've talked about, in spite of all these incredible programs and our commitment, there's still a huge need that we need to meet. So we can do better. And our question that we have here that we'll do through this Jamboard, if you can click on the link in the chat to the Jamboard, the question is, what is one goal you hope UCSF and VSFG will accomplish in the next 1 to 3 years to better support the mental health and well-being of children, adolescents, and/or families? And this is really going to inform the next 2 sessions. So please post the goal that you have, and we really appreciate your input. We'll just have like 4 minutes to engage in that. And I forgot to go through the instructions that were on that slide, but you just click on the sticky and you can post, change colors and stuff like that. We see a streamlined triage system across UCSF mental health clinics. Increase the availability of psychotherapy so it doesn't take a miracle to obtain it. For primary care to have more meaningful partnerships with school leadership, school-based health centers, and school-based mental health support systems. Definitely a gap there overall. Appreciate some of the models we have that exist, but as I mentioned earlier, not the norm, and it seems like it's fairly siloed overall and not coordinated from the patient perspective or the provider's perspective, unless it's like really embedded like we saw in Oakland. So so many great ideas here, or not great ideas, but great goals. one EMR billing system. Yeah, partnerships across our sites, so ZSFG and BCH. And that again, like our social needs task force, even though mental health is not a social need, we realize that it's a collaborative space across disciplines and sites and service areas to share and learn. And we are focused on mental health right now just because that is the topic that was on everyone's mind. Awesome. We'll have 2 more minutes. Keep posting them up there. Partner with other local health systems to scale the use of PEARLS assessment. There's so many, so I'm sorry if I'm not reading all of them, partly because I can't see them all. I'll go to the link itself and out here it is, yeah, and I can expand. Consolidated or organized access to all these resources so we know what resource already exists and who qualifies 100%. Like some of these programs, many of us probably didn't know about, and that's just like a sample. And it's hard to know. And also a lot of sites are creating their own resource lists and things like that and have algorithms they've developed, and it would be great to be able to share and learn and streamline it. Okay, we'll just take 1 more minute. Navigator for every patient. It'd be so great. And I think we definitely have to collaborate with our health plans, of course, because the care coordination part and the mandate from the state is with the health plans, and probably a tremendous resource that we could leverage better and collaborate with. Okay, well, thank you so much for all these ideas. Keep posting away. We even though it's not showing the chat, the Jamboard's active, and we will consolidate all the goals that you've listed. And we are going to close as we began, and I'm going to bring back Saun-Toy.
Thank you. And I really just want to thank you, Dana, Cassandra. We're all committee, but every committee needs folks to kind of pull us together and gather. So thank you for your leadership. Just a quick summary, right? So we grounded in health equity. We did a look back. We did Sankofa. We honored our land, our past, our guides. We recognize that there's more need than capacity. We heard from and we were informed by the brilliance of Malia and Tony, and heard their voices, right? We heard from Oakland Thrive, some deep listening that they've done and that they're sharing out with us about the impact of violence and the important need for safe spaces, right? It's not only, it's clinical and non-clinical interventions that we need. Thank you, Dr. Amy, for that overview of specialty and non-specialty mental health. It is actually good information to ground us all. Anda showed us kind of the mapping, right? And even though the mapping might be incomplete, of course, some things are there, some things are not there, some things are emerging. It is illuminating, right? It shows us the gaps. It shows us the possibility of wholeness. And very, very helpful. And then we got to hear of just a few of the amazing behavioral health programs that are across our system. And so I was really happy to learn from them. We will summarize and have a next session on May 24th from 1 to 4. So please mark your calendars, and we have some fabulous speakers. Session 2 is titled An Unprecedented Reform Landscape in California and What It Means for Bay Area Children and Families. And we'll be building upon the landscaping and mental health services map detailed in this session, and have the opportunity to meet with some great leaders who are re-envisioning California's system of care. We'll take a deep dive into some of the unprecedented state reform around behavioral mental health. And I don't know if folks remember when the policy change for mental health Medi-Cal for all, including young people who were undocumented. I remember when that happened, that policy change, and it showed me as a clinician on the ground that there are people working all over for collective change and health and well-being. We will have Alex Briscoe, who actually was one of the first clinicians at our school-based health clinic at McClymonds, and now the principal of the California Children's Trust, Mark Galley, Secretary of the California Health and Human Services. Tom Insel will be here, former director of the National Institute of Mental Health. Melanie Moore will join us back with Oakland Thrives. We'll have Ann Kuhn, who is the CEO and president of the California Children's Hospital Association, and Lisa Fortuna, who's the chief of psychiatry at Zuckerberg. Oh my gosh, how could you miss it? So make sure that you come, bring yourselves. We need all of us in order to make the change that we know that is needed. And then for session 3 is moving from promise to practice. Again, just thank you so much. This is an example of collaboration, of transparency, of partnership. Just deep gratitude to our medical partners, our pediatric partners who are leading this and see the need, and bringing us all together as a community to develop, design, build upon, and create solutions for our children, our families, and adolescents and infants. Again, as Dr. Petra Steinbuchel said, we all have mental health, emotional health, and well-being. We are shifting the conversation. So please take good care of yourselves. We will post the evaluation link, so please give us your feedback. We need it. We value your feedback, and we'll integrate it into the next series of sessions on session 2 and session 3. And share with your colleagues. Come back, come back, come back, come back. Thank you, thank you, thank you for all the incredible work that you are doing, that you have done. We appreciate you. Be well.
Thank you, everybody. See you next time. Please reach out.